Listening test. This test has 3 parts. In each part you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for Extract 1. Extract 1. Questions 1 to 12. You hear a physician talking to a patient. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good afternoon. Good afternoon. May I know your problem? Well, doctor, I am a patient with coronary artery disease and peripheral vascular disease with prior stent-supported angioplasty. I'm having a persistent cough for the past 2 weeks and some shortness of breath. I was also treated for pneumonia. Do you feel any chest pain, pressure, or heaviness in chest? No, doctor. What's your age? 60, doctor. Do you smoke or drink? Well, I don't drink, but I'm a regular smoker. May I know your past medical history? Well, I have coronary artery disease since 2016, peripheral vascular disease for over 10 years, chronic obstructive pulmonary disease, and hypertension. Did you undergo any surgery in the past? Yes. Right fern popliteal bypass about 8 years ago, neck fusion in the remote past, stent-supported angioplasty to unknown vessel in the heart. What medications are you taking? Aspirin 81 milligrams daily, clopidogrel 75 milligrams daily, allopurinol 100 milligrams daily, levothyroxine 100 mcg a day, lisinopril 10 milligrams a day, metoprolol 25 milligrams a day, atorvastatin 10 milligrams daily. Are you allergic to any medicine? Yes, I cannot take aspirin because it is intolerant to my stomach. I get stomach upset. Okay, well, your physical examination result shows your body temperature is 97, heart rate of 90, blood pressure of 187 over 105. Cardiovascular studies show normal upstroke, distal pulse symmetrical. Heart regular with a normal S1 with normally split S2. There is an S4 at the apex. Lungs with decreased air entry. No wheezes. Echocardiogram shows mild biatrial enlargement, normal thickening of the left ventricle with mildly dilated ventricle, EF of 40%, mild mitral regurgitation, and diastolic dysfunction grade 2. Nuclear stress study shows fixed infralateral defects, no reversible ischemia identified. Laboratory data shows normal white cells, hemoglobin 11, BUN of 12.1, creatinine of 0.8, troponin of 0.04, BNP of 5700. Your premature ventricular contraction is random. You had runoff 3 beats consecutive 1 time. The patient denied any awareness of that or syncope. Did you have any temporary loss of consciousness related to insufficient blood flow to the brain? We term it as syncope. No, doctor. Actually, I'm unaware of it. Okay, you have cardiomyopathy, ischemic exacerbation of symptoms. Electrophysiology study is required for ventricular tachycardia. Defibrillator will be determined at a later stage. Continue with metoprolol with a little higher dose of 25 milligrams twice a day. Continue atorvastatin. Increase lisinopril to 20 milligrams daily to improve blood pressure management. Take hydralazine 50 milligrams for blood pressure management. Okay, thank you, doctor.
Extract 2. Questions 13 to 24. You hear a doctor talking to a patient. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Good morning. What's your problem?
Well, I have a headache and pulsatile tinnitus. For the past 3 months, I've been getting severe headaches, and almost daily. I'm getting pulsations in the head with heartbeat sounds.
Exactly at which point of your head do you feel pain?
On top of my head.
Are you getting nausea or vomiting associated with the headaches?
No, doctor.
Is there any previous history of headaches?
No, doctor. But apart from last 3 months.
What's your age?
44, doctor. When I speak on the phone, I get weird sounds in my left ear. I get pulsating sounds only in left ear.
When did this problem start, actually?
Well, actually, the ear pulsations began following a flight trip to my native place.
Is there any drop or change in hearing?
No, doctor. But I had dizzy episodes in the past with nausea being imbalanced at times.
Is there any change in your vision?
No, doctor.
Well, do you smoke or drink?
I do not consume alcohol, but I used to smoke 1 pack a day, and now I have completely stopped it.
Have you had any previous illness or surgeries?
I had skin cancer on my arm and back. I am a kidney donor, so I had a left nephrectomy, C-sections, mastoidectomy, laparoscopy, and temporal arteritis.
What medications are you taking?
Tylenol, Excedrin, and a multivitamin and probiotic.
Are you allergic to any medicine?
Yes, to codeine and penicillin.
Tell me your family history of illness.
Well, my father has a cancer, hypertension, and heart disease.
Your physical examination shows your blood pressure at 120/78, pulse 64 and regular, and the temperature is 97.4. Cardiovascular test shows regular heart rate and rhythm without murmur. There is an old mastoidectomy scar on your left ear. Weber exam is midline. Grossly hearing is intact. You have pulsatile tinnitus. Left ear with eustachian tube disorder as the etiology. There's also a possibility of normal pressure hydrocephalus, deviated naval septum, dizziness, probably due to possible Meniere disease. I would recommend you to start a 2-gram less sodium diet. I am ordering a carotid ultrasound study as part of the workup and evaluation. Since your disease is related to eustachian tube, I'm prescribing Nasacort AQ nasal spray, 1 spray each nostril daily. You use the hearing protection devices at all times. I will recheck you in 3 weeks.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Question 25. You hear a nurse talking to a patient who's about to have a mammogram. Now read the question.
So, have you had a mammogram before?
No, I haven't, and I do have a few questions actually. Like, what about the radiation? Do I need to worry about the dose? Is it likely to be harmful in any way?
No, it's very low. In fact, it's similar to the amount you'd receive if you took a long-haul flight.
Oh, yes, that reminds me. When will I hear? 'Cause I'm away in New Zealand for a month from next Wednesday, and I'd like to know as soon as possible.
It'll take about 2 weeks, but if you're concerned, we can give you a number to call.
Oh, thanks. That'll be a real help, actually. Then, for me, the big question is it going to hurt? I've been hearing gruesome stories from friends, and my anxiety levels are going through the roof.
Okay, I understand. Perhaps you could tell me exactly what you've heard.
Question 26. You hear a doctor talking to a patient about a blood pressure monitor. Now read the question.
It's like a normal blood pressure monitor, but it's mobile. You wear it on a belt around your waist and it's attached to a cuff on your arm. Then you just go about your usual day-to-day activities and it takes your blood pressure at regular intervals. It's more accurate because we can avoid what's called a white coat syndrome. It beeps first, usually every 30 minutes or so. When that happens, you should sit down if you can, hold your arms still and keep the cuff level with your heart.
Do I have to wear it at night?
Yes, you do. You could put it under your pillow. It needs to stay on for 24 hours, though you don't have to wear the belt.
What about showering and stuff?
Well, I was about to say, you should avoid that, I'm afraid.
I see.
Question 27. You hear a dentist and her assistant talking about a problem with some sterilizing equipment. Now read the question.
Oh, no. It looks like the autoclave is playing up again. The temperature's only 117. That's 4 degrees lower than I set it for.
Yeah, I noticed that. Yesterday it was at 119 and I just couldn't get it to go any higher. Shall I have a look in the instruction manual and see if I can sort it out?
Well, that might invalidate the warranty. Could you find out whether the one next door's working properly? I expect it's because the hard water around here has caused a build-up of scale and that's affected its efficiency. Perhaps you could ask reception to get the company to come out as soon as possible. If they can't come tomorrow, we'll have to wait until Wednesday and make sure everyone knows it's out of order. If you could send a quick group email, that'd be great. That's the second time this has happened, and it's still under guarantee.
Question 28. You hear a GP talking to a patient with hay fever. Now read the question.
How can I help you today?
I need something to help me manage my hay fever this summer. It's already become unbearable. I don't want to have to stay indoors when all my mates are out enjoying the good weather. We're all off camping next weekend, and I'd hate to miss out on that.
What's bothering you in particular? Perhaps I can give you something to make you more comfortable.
Well, I keep getting this horrible headache thing. It's like at the top of my nose, and it's really getting me down, to be honest. Then there are the watery eyes. I mean, I can feel them puffing up as soon as I leave the house. They're so itchy, red and painful and look awful. I've got a summer job working at music festivals, so there's no escaping. I'm literally in fields all day, every day. Is there something you can give me?
Question 29. You hear two nurses doing a patient handover at the change of shift. Now read the question.
So, in bed 6 we have 83-year-old Mr. Beard.
OK.
He was admitted this morning and he's been diagnosed with bacterial pneumonia of the right lung. He's quite poorly at the moment, but stable. He's lactose intolerant, so can you talk to the kitchen and organise something suitable for him?
OK.
Otherwise, he has no known allergies. He's been for a chest x-ray, but we're still waiting for the results to come through. We may need to do a CT scan too, but we'll have to wait to see what the x-ray results reveal before we can arrange that.
Right.
His SATs were at 57, so he's on 2 litres via a nasal cannula, and that's to be reviewed after 2 days, so not until tomorrow morning.
Mm-hmm.
Oh, and I forgot to mention, he had a fever of 39.4, so he's also on antibiotics via IV, which he's not very happy about.
Question 30. You hear a hospital manager briefing newly recruited staff about patient safety. Now read the question.
Within the information team, we provide a set of standard and custom-made reports to suit the needs of staff and patients. Our aim is to provide information into the patient's journey, from their arrival in the emergency department to their discharge from outpatients. One of my responsibilities is to ensure that the information we provide is clear, easy to understand and straightforward to use, so that we can look at areas of concern, things that are common across departments, and reassure ourselves that we are delivering quality care. When things go wrong, we're able to provide information from the system to enable the staff responsible to review the situation, understand, and learn what needs to be changed to avoid future events.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best, according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with a scrub nurse called Joanna Swan. You now have 90 seconds to read questions 31 to 36.
Today, I'm talking to Joanna Swan, who works as a scrub nurse in the operating theatre. Joanna, firstly, remind us what a scrub nurse is exactly and where the name comes from.
Sure. Well, perioperative nurse is the correct term, of course, but basically we're all familiar with the notion of scrubbing in. You know, you've seen surgeons doing it. It's not just washing your hands, it's doing that very thorough cleaning to ensure you're completely sterile before you go anywhere near the patient or the surgical instruments.
Mm-hmm.
But the name scrub nurse doesn't quite capture the full role. I mean, basically, your job's to prepare the operating room for surgery. You lay out the instruments, hand them to the surgeon when asked, and you're also responsible for monitoring the patient. So you're like the bridge between the surgical team and everyone else who's supporting the patient.
So how did you first get into this type of nursing?
I remember one of my most formative experiences as a student nurse was shadowing a perioperative nurse in theatre. I had to scrub up too, and I was expected to lend a hand because they didn't want somebody just standing around in the way. It was all new to me, and I was worried how I'd react. I was fine around blood, but I'd never seen a wound being created before. It was a 30-minute hernia op, so nothing special, but it left a deep impression on me. Then later, when I'd reached the stage in my career where I was up for a challenge, that image came back to me.
And what sort of background do you need to go into this kind of nursing?
Well, you can do specialist courses, but I think what's crucial is having a fair amount of nursing experience, particularly in critical care settings. That was true of me, and there's really no substitute for that. To be honest, the job wouldn't suit everybody. The hours can be gruelling, and the work's very demanding. You can't just pop out to the bathroom or have a snack when you feel like it. And you're stuck in a small room with some quite strong personalities who are also under pressure.
So it's a very intense environment, but also a very rewarding one.
And what skills does it call for?
Well, basically every second counts. You've got to be very efficient and able to think ahead and get things organised. What needs doing immediately, what can wait a few moments, what you need to do now because you might not get the chance later, and so on. I mean, that's the kind of thing you can train somebody for up to a point. But to do it well, you've got to be in the mindset to start with. Attention to detail is crucial. If that's not how you are, then you're not going to be right for the job. You have to be there mentally 100% as well as physically.
And I guess the idea of the team is really important in theatre.
Indeed. It's got to be part of the system. I mean, especially when you're on call, you never know who you're going to be working with. For an operating theatre to run smoothly, there's got to be clear communication and coordination between everyone concerned, because it's the collaboration within the team that keeps patients alive. In my hospital, to promote team spirit, we set great store by meetings. The preoperative briefing, of course, but also meetings to discuss issues and generate new ideas. As a nurse, it's great to feel that your voice counts, and that's not always the case in medicine. So for me, that's a big plus. We also take opportunities to debrief staff after difficult events. I mean, that's crucial too.
And what about the interactions with the patients?
Well, some people have the idea that in the operating theatre you're going to be having just mechanistic interventions on patients who are in no position to respond or interact with the nurse, that you're just providing support to the surgeon and the anaesthetist. But these days, theatre nurses are required to have a holistic, patient-centred approach to care, and this extends beyond the period of the patient's actual surgical experience. Preoperative visitings become the norm, so that patients see a familiar face when they come in for treatment, and this can really reduce stress levels on the day for the patient. For me, this is a really positive development, and I'm always keen to take on that role.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear a junior doctor called Graham Holder giving a presentation on the subject of hand transplants. You now have 90 seconds to read questions 37 to 42.
Good morning. My name's Graham Holder. I'm a junior doctor here at the hospital. The subject of my presentation today is hand transplants. I'm not a specialist in this area and I have no direct experience of it, but I've always found it fascinating and I'd like to share my interest in it with you. So, first of all, what is a hand transplant and why is it better than prostheses? Well, it's a type of a CTA, that's a composite tissue allotransplantation, in which skin, fat, muscle and nerve bone are all transferred from one person to another. To date, it's largely been used to treat patients with both functional and aesthetic deficits that can't be dealt with by conventional methods, but this is changing. The mainstay of treatment for amputated limbs has long been prostheses, but patients often reject them because they only provide limited mobility and function, and they can be uncomfortable. In theory at least, transplanting a complete part should give much better results than even the most advanced prosthetic technology. So, more and more upper limb transplants are being performed around the world every year, and this is largely thanks to new and more powerful immune suppressive drugs. The strategies in use have been derived from the experience of transplanting organs, especially kidneys, and this has also informed the choice of drugs. Slightly higher amounts of immune suppression are used with a potent induction, followed by a low-dose maintenance regime. This regime can be supplemented by short courses of intensive therapy to overcome any episode of acute rejection. The survival rate of both patients and grafts under this regimen outperforms that for all other transplants. That's actually pretty impressive. At least one episode of rejection is recorded in 90% of cases, however, despite the immune suppressive protocol, and this is much higher than with kidney transplants. One reason for this is that hand transplantation represents a visible graft. That means you can make an immediate diagnosis of rejection based on minor changes in skin appearance, even though this has to be confirmed by a biopsy. If patients adhere to the regime, however, rejection is generally reversible. One of the challenges of hand transplantation is to achieve the delicate balance that prevents rejection whilst at the same time protecting patients from the direct toxicity of the medicaments. But this seems to be working, and infection is actually the commonest complication. So, what happens during a hand transplant operation? It's a 6-hour procedure which involves 2 separate surgical teams, one removing the hand from the donor and the other working with the recipient. Bones are joined with titanium plates and screws. As with other bone grafts, they should eventually heal together, but the plates are left in to ensure stability. Surgeons then connect key muscles and tendons before tiny blood vessels are connected using surgical microscopes. 3 major nerves are then attached, followed by large and small veins. Once blood is circulating, the recipient begins to feel the new hand. A recent case attracted a lot of interest in the UK. It was a bilateral transplant for a man who'd lost both hands in an accident at work. Now, bilateral transplants aren't so uncommon, but what made the case particularly noteworthy was the fact that he still had both his thumbs, but not the rest of his hands. So it wasn't a transplant performed at the wrist, as is usually the case, but in the substance of both hands. Nonetheless, immediately afterwards, he managed to gain some movement in his donor hands and has since improved dramatically. Indeed, just 9 months after the procedure, he was able to write a thank you letter to the surgeon. His recovery experience mirrors that of most transplant patients. The incredible thing about him is the speed at which he's gained that functionality. So, what about donors? One of the challenges of hand transplantation is that the hands not only have to fit immunologically, they also have to look right because they're going to be on view, an issue that doesn't arise with internal organs. That makes the job of finding an appropriate donor even harder. In any case, because hand transplantation is rather unusual, people have been slow to donate, and there have been occasions when surgeons had to ask for a donation when somebody's offered other organs, but not specifically the hands, and that's a really difficult thing to negotiate with next of kin at the time of death. The hand transplant program is now established and it's becoming mature. It'd be nice to think that hand transplants could become as routine as kidney transplants. Setting up a donor network is the next goal.
That is the end of Part C.